things that are going on. Yet many of the colleges, many of the faculty, many of us are not very clear. There are gray areas we feel, and some things are not interpreted, not clear. And assessment, especially regarding, because CBM is also about assessment, and assessment, a lot of confusions are there. So when they requested me to talk on something on assessment, I thought blueprinting would be the right idea, because blueprinting is the one which is going to guide us towards through the assessment. So let's see regarding the what you say, blueprinting in assessment, and we see how we can go about it. Okay. I carry greetings from JNMC Belagavi and KLE Academy of Higher Education from Belagavi, our university. So the topic today we are going to discuss is blueprinting in assessment in the context of CBM. So my objectives for the next 45 minutes so would be, by the end of the session, participants should be able to understand what is a blueprint, what need for the blueprint, steps to prepare a blueprint, and a role of blueprint in CBME curriculum. So now, can I have some interaction that now, so what is the current scenario of a traditional assessment in a medical education? Not about CBME, traditionally what is going on now? What are the common responses of the students? Like, generally we ask certain, when the exams are over, we are also curious what was the examination paper. So when we ask the students, what is the common responses that we get? Can I have some inputs from here, participants, as well as if you can put in somebody, online people can put it on chat. What are the common responses when we ask about the theory examination? When they come out of the theory examination, what are the common responses that we get? We ask them, how was the paper?
Yeah, either the paper was easy or tough.
Out of syllabus? Yeah, there was out of syllabus. It was too easy.
Yeah, too easy.
Too lengthy.
Too lengthy.
And repetition of questions in paper. There was in paper 1, paper 2. Yes. Dr. Mahesh Kumar is saying online lengthy. Yes. Yeah, exactly as you all rightly said. Too lengthy is one of them. They said I knew so much, there was no time, didn't know what to write. So there was so much to write. It was too lengthy. Then they said too vague, don't know what to cut, what to write. There was questions were so vague, it was all lengthy, and then I didn't know. I knew so much, I didn't know how to cut down, where to cut down. Usually, what happens is in a traditional examination, there are 3 variables: paper setter variable, a student, the one who writes, and there is a paper assessor. Exactly, assessor variable that. Each one of them have something about that particular question, some expectations, some perspectives in that. So their perspectives is different. Students write on their own, thinking something. The paper setter would have expected something. The evaluator would have expected something. So there is it's like 3 blind men describing an elephant in their own way. So whatever they perceive. So this is what is the 3 variables happen. Then we also have long questions were bouncers. Sometimes they come out of syllabus. Long questions were bouncers, and they come up with that, that. And they say that all the questions were few topics only. There were no question. I studied so much yesterday, CVS, RS, and this and that. I studied not even single question from that. There was so many other questions were concentrated only on few topics, right? And as rightly put by madam here, there's an overlap of questions paper in paper 1 and 2. There was, same questions were asked here. Also, same questions were asked. Also, in the same, there was an overlap. Okay. Now, what happens if you ask the questions when they come out of the practical examination? After the practical examination, what are the common thing we get? Common responses we get from the participants. From the students. Less time. There was so less time. The long question was given very less time. I didn't have time to completely evaluate and write. Exactly. Absolutely. Thank you. Then. Don't they say that long question was something that I didn't want actually? Because usually the students know the cases. Mujhe ye chahiye, mujhe wo chahiye, and they know the cases, and then it happens that they don't get the cases that they want. So, or something they don't want. They get the cases that something they don't want, right? Usually, perception is that CNS cases in medicine we don't want. So they say that usually the time was too short for a long case. I didn't get time for that. Yeah, he's saying rare cases, which was not exactly. Thank you, Dr. Mahesh. So rare cases. And then long case was CNS. Oh God, I didn't want that. I was praying all the time that I should not get, and I got that. So, and my patient refused to give proper history. My patient didn't give history only. Maybe because of the language problems, or the patient was bugged up all the time, responding, every day, because they are exam cases. And then, everybody going and asking them, maybe didn't give the history properly. So that then I didn't get case I wanted. I'm going to fail. This was not, I didn't do well. This was not a case I wanted. They have students have the perception and they feel. And this also very commonly it happens. Previously, some seniors, PG, somebody would have told that case mein isme murmur hai, and the patient is not, the student is not, it happens. Quite common, right? Okay. Probably I can say that I have been in all these cases. I have been in all these situations. Each one of us can relate to something at least here. Okay. So I didn't find any, these are the common things, common problems, what they face. Okay. Now, why do you think this happens? Why do you think this happens? Can we get some inputs?
Vague.
Because the question papers are vague, so it happens. The question, why the question papers are vague? Yes.
Structure.
No uniformity.
No structure. Yes, no structure.
No uniformity in preparing.
Yeah, no uniformity in setting the question papers, right? So probably, is it the students that are wrong, or is it there's something wrong with us? Both. In this matter, sir, right? You're right. But in this case, what we are talking.
Yes.
Yeah, to some extent, what he's saying is right. Some of the things that I don't want this case, I don't want that case, particularly keeping those things in a mind is a student's problem. But then theory questions and all, if you see, most of the things are concerned with us, that where we are going wrong, right? So this happens because in a traditional system, question paper is set by one examiner. As I said, there are three variables, right? So the content of what to assess is left to the decision of individual paper setters, and validity is the need of every assessment. We know that every assessment has to be valid, and the content in examination of the syllabus is called as content validity. The validity that is related to the content that is distributed in the examination is called as content validity. So what we are talking of blueprint is related to this content validity. So, and the content of assessment is said to be valid when it is congruent with the objectives and learning experiences. What happens is when the out of question, out of syllabus, the bouncers, what we talk, are usually, they may not be there in the syllabus. But then students say that I have not been taught all this. Why it was not taught? Probably it was not there in the objectives. So it was not taught. But suddenly it appears in the examination. So our assessment system has to be in congruence with the objectives. We have to stick to objectives. That is one lesson that we have to learn out of it now. So for all these problems, the answer, what is an answer to all these problems is the blueprint. Yes, we cannot say 100% it makes it valid, but it increases the validity. Definitely it increases the validity. Okay. Now, all these problems as it is, we are discussing about the traditional examination system to overcome this, and the answer that overcomes is our CBME that we are facing now, that we are dealing with now, right? CBME answers most of these, because one person is not setting, we have to have all the assessment system in place, and only the assessment, the summative assessment is not that only one that decides the students' weight. So there are so many other things that have changed. So we'll see how we go about blueprinting and its context in CBME. Now, the blueprint, as we all have heard, blueprint is derived from the domain of architecture, which means detailed plan of action. We all know that, right? What is a blueprinting in assessment? In assessment, it is a map and a specification for an assessment program that ensures that all the aspects of the curriculum and educational domains are covered by assessment programs over a specified period of time, right? So what is important here is, one is the map. It's a map and a specification of an assessment programs that ensures that all the aspects of the curriculum, all the aspects of not just summative as examination, all the assessment of, aspects of curriculum and educational domains are covered by assessment programs over a specific period of time. So that is a blueprint in assessment. Okay, now why do we need a blueprint? Can I have some inputs? Because this is a post-lunch session. Let us have some interaction. Okay. Why do we need a blueprint?
Structure.
Yes, this will be structured. Since this is structured, yes, we get some structure. Very nice. Thank you so much. It is structured. So we know we can focus on objectives, what is needed for them, what is a must know. Now we talk of core and non-core competencies. Okay, for standardization. Yes, Dr. Sharmila says it is for standardization. Yeah, as a standard set of questions. Yes, it increases the validity. Thank you, Dr. Mahesh Kumar. Yes, it increases the validity. Exactly, madam. It acts as a guideline or a guide for a teacher. Because we know, instead of just asking randomly what, some thoughts, most of the time when we set question paper, it happens, we tend to ask our own questions, our own favorite questions. Every time if I am a setter, naturally I'll ask the questions that I have taught. I'll focus on that. Oh yeah, somewhere, without our knowledge, we do that, right? So this is not there. So there will be, Dr. Hilda says that is uniformity across the faculty in the universities. That is very good. And then weightage on topics. Dr. Arvind says that there has to be appropriate weightage. Very nice. Thank you, all of you. Right, like you all rightly said, it makes an assessment. It makes the assessment clear, explicit, and transparent. Okay, and it helps to match the various competencies with the course content and appropriate modality of assessment. That means whatever the competencies are there, the course content and what modalities have to be there. So there is a appropriate match for what to assess. It makes the assessment fair to the students as they can have a clear idea of what is being examined. So they will know if the blueprint is there, they will know what is expected out of them, out of this syllabus. It helps the teachers in designing the instruction as per the guidelines. Blueprint deals with the sampling content, competencies, and tools for the assessment in a rational and a balanced manner. So all these tools, there are I'm sure now with CISP and CBME that has come, so many tools we have learned, new tools, workplace-based assessment, so many newer things we have learned, So it deals with all of these in a content as well as those tools in a rational and a balanced manner, where which tool has to be used for what competencies. And the aim of blueprinting is to reduce the two major threats to validity. That is, one is undersampling, the other one is a flawed questions. Undersampling is too little weightage for a topic of a national importance, national health importance. Very important topics we feel, national health importance, that is common, that should have been asked, and those will be ignored. So that one that is called as undersampling. Or sometimes what happens is there is so much in a portion, we talk so much is there, but we have to ask only these many questions. So how can you ask? How can you do justice? But then we have to go by weightage. So that is there. Then flawed questions. Sometimes, too easy or too difficult questions or examiner bias, which should not have been there, maybe out of the syllabus, maybe out of the fantasy of a paper setter that, okay, let us see how the student will answer. And these kind of questions, they're all flawed questions, which should not have been there. Okay. Now, what are the steps in preparing the blueprint? Okay, so there are basically 5 steps we talk of. The first step is define the scope and purpose of the assessment. That I'm sure we will do that. Of course, we will be doing that. We don't call them as one particular step. We know if we are setting paper, whom we are setting, for what level setting. Is it for summative examination or a formative examination? We know that whether it is an internal assessment or a final examination, university has asked. So we'll know what level of UG or PG formative and all that we will know. Whether it is assessment of knowledge, skills, attitude. So we know that. So that this is just for a formality, this is that. Now the important thing is a step 2. Step 2 is decide the weightage to be given to the content areas, domains of learning, and methods of assessment. That means weightage to be given to the content areas. How do we decide weightage? How weightage to be given to the important content areas? Like, okay. Now, how do we give weightage? Suppose if there are so much of syllabus is there, how do we, can I have some inputs? How should we decide the weightage? Clinical application. Very good, madam. Thank you so much. One is by clinical application. And anything? Yes, sir. Diseases or topics of a national health importance. Very nice. So how do we decide still that weightage? Because sometimes there can still be subjectivity. When we sit in the department, I might feel that tuberculosis is more important. My colleague might feel that no, diabetes is more important. Ultimately, both are important. Somebody will say, no, MI is more important, because it's more common. Now, though, of course, nothing is more important than the COVID. Okay, COVID has changed a few of our dynamics. So for that, to come to a consensus, what we have is there is something called as that impact, and we can calculate the impact as well as the frequency of impact of the disease in terms of its impact on health, and its frequency of occurrence. There are some diseases which have a high impact, but may not be very frequent. There are some diseases which are very frequent, they may not have impact. Right? So comparatively, if you say, yeah, okay. Yes, exactly. Geographic distribution, we have to consider if you're considering the national health importance. If some diseases are the endemic area, we have to look at that. That's what, it helps us deal with all those things. Yeah. Incidence of disease in population, yes. Okay. Okay, so these are all the things that we need to consider. So because for that, what we can do is we have a calculation. Consider one is the impact of impact on health, and the other one is its occurrence of the frequency. Now, if you take in a relative manner on maybe on a lighter note also, we can take COVID in the first wave had high impact, but it was not as common as it is now. But if you see now, it has become much more commoner. The frequency is more, but the impact has reduced. So like that, we have to consider both. So what we have to have calculation is the impact is considered as I and the frequency is considered F. Then the weightage is, that is W, that is weightage is equal to I into F divided by T. T is sum of products of I and F. I'll show you the table, how it is I and F is there. Okay, now don't tell me now the Sunita madam we thought she's going to talk about blueprinting and she's talking something about maths. No, I also don't like maths actually. Okay, so this is nothing to do with maths, just a simple. So if you take a topic here, if you can see here, this is perceived impact is I and the frequency is F and I into F is there. And this is the weightage that is to be calculated. Is my cursor seen there? No. How can I get the cursor? Laser or pen I can use? Oh, okay. So here is a topic and here is an impact and frequency and I into F, then we have to do that. Okay. So if topic 1, for example, okay, I'll go further. Now, how to consider this impact? How to consider this as what is impact? Now, what is high impact? What is low impact? Again, otherwise there will be again subjectivity. What I feel might be high impact. Somebody else may feel that is low impact. So perceived impact is one number is given for non-urgent little prevention potential. The diseases that have non-urgent little prevention potential is given number 1. Then serious diseases but not life-threatening is given as 2. Life-threatening emergency can be given as 3. Suppose if I'm taking a cardiovascular system, maybe vasculitis or some of the myocarditis or some maybe cardiomyopathies can be non-urgent little prevention potential. Okay, and serious but not life-threatening maybe hypertension, okay, to be considered. It has its consequences, may not be very life-threatening, but if a life-threatening emergency, then I can take an example of myocardial infarction. So like this, if we go on dividing, give that impact, that. And how we have to consider the frequencies that rarely seen is 1, relatively common, and very common is 3. Okay, so we go on giving 1, 2, 3 number for the frequency as well as for the impact. Then we might come to that some number there that we need to calculate. Okay. Now, for example, if you take topic 1, again, if I say topic 1, you can take it as vasculitis or any topic you take for any disease. If you take, if the impact is 1, that is non-urgent, very little potential, and then frequency is 2, relatively common, then I into F will be 2. Agreed? Now, for another topic, it may be 2 and 2. Maybe if you take again hypertension or diabetes mellitus, serious but not life-threatening, relatively common, and so 2 plus 2 into 2 it will be 4. Okay. So another one, myocardial infarction, quite common and life-threatening, take it 9. It need not be same always. It may be 3. It may be 2 into 3. It may be 2 into 1. It may be 3 into 3. It may be whatever combination, depending on that. So ultimately, we have to get this I into F. So weightage for each particular topic is that I into F divided by T. T is total sum of this I into F. So for every topic, for example, if I'm taking for the topic of vasculitis, it is 2 divided by 15. That is I into F divided by T. If you take 2 divided by 15. For this topic, Hypertension, it will be 4 divided by 15. That will be 0.27. Then for another topic, it will be 9 divided by 15. So as the number total I and F goes on increasing, the weightage goes on increasing. Okay. So this is how we have to calculate. And overall, if you take total, this will never be more than 1 for all these topics, because it will be never be total. It will be no more than 1. So now you can convert them into number of questions. How many number of, consider the weightage in terms of percentage first, and then see how many. See, out of 100, if I'm getting 15% for one of them, then maybe out of 100, 15 marks I can keep it for one particular topic. Got it? Okay. Now this is for the diseases on a clinical side. Now what happens on the preclinical side or a paraclinical, some of the paraclinical side? Can anybody tell me? Clinical, as madam also said, clinical application. Rightly said. Thank you very much, madam. So as rightly said by you, it is about the, okay, this is, I had just put the same many examples, vasculitis and atherosclerosis and MI. Like this is just for an example. It may vary. Again, you may ask that somebody says that, in the, somebody says that vasculitis and it may not be, atherosclerosis may be 1. It may be not very urgent, not urgent, and not very this little preventive potentially. Maybe it comes in 1. Okay, you decide. The department, faculty, you are subject expert, you all can sit together and decide whichever is the majority. That is why we cannot do any of these things alone, because again the element of subjectivity comes here. So we will have to sit with subject experts, decide together the content areas and all these weightage and all that, and that has to be done. Okay, now for basic sciences, like I said, ultimately it is on the clinical application. No or a little clinical application is 1. There's no calculation. It is very simple here. Moderate or a clinical application and high clinical application. Again, the question comes here, subjectivity. So what we have to do is the respective departments have to call the allied, their clinical departments, call the experts and sit actually clinically how much is the application of these. Anatomy can call, can involve surgery, gynec and all surgical branches, orthopedics or whatever, all surgical branches. Physiology can cause physiology, biochemistry related clinical branches. You can involve them and sit around and discuss, because they are the ones who are really going to tell us which is the clinical application, what is the maximum clinical application where it goes. So based on that, we have to content. After having said all this, correct, but still it is, practically we cannot make it 100%. Yes, this is there. There will be some, but definitely it will improve our content areas, and definitely it is going to improve our content validity. Okay. Now, after doing this, yes, sir. Yes, sir.
Do we have any ready example to consider 1, 2, 3 like that?
I didn't get you, sir.
At the national level, do we have any ready?
No. We don't have, sir. These are all the recommendation by the experts in the education area. There is no recommendation by NMC that you have to consider this only as 1 and this. That's why it is left to the subject experts.
So this will be vague, it's not.
No, yeah. We cannot say it as vague. Of course, it is left to the again for the area. See, again, suppose if you take thyroid, it may be endemic in some areas. So they may be considering it. For them, it may be important. Thyroid, I mean to say hypothyroidism or iodine deficiency and these things. Suppose if you take thalassemia, it is endemic kind of, it is so much of this thing in our areas, some of the areas in Karnataka, North Karnataka and Maharashtra, we have a lot of these. So depending on that area, they have to subject experts. They know, they're experts. They have been into the field. We cannot for everything, expert that this thing. Of course, as of now, there is nothing as a mandate or recommendation from anybody. These are the suggestion by the experts. This is how we can go about it. The next step is decide the total weightage and number of items to be included in the assessment. How many, now once we have decided totally, what is our total marks and how many items we are going to include based on weightage. Okay. Then decide on the table of test specification. Now the comes when we start constructing the blueprint or a grid or whatever we call it as, there we can have variety of blueprint or the variety of specification, tables, like whatever we have blueprints. We can have vast, I have an example for all of that, we'll say. So ultimately it is up to us what we want. Based on our need, we need to prepare a blueprint. Okay. Then prepare an individual question, then structuring and individual questions and all this will come. Now, just to sum up, the 5 steps that are involved in preparing the blueprint are: one is define the scope and purpose of the assessment, decide the weightage to be given to the content areas, domains, and the methods of assessment, decide the total weightage and number of items to be included in the assessment, and then decide on the decide on the table of what kind of a table we want the test specification. After doing that, then start constructing the questions. So this is about constructing the or preparing the blueprint, some steps to prepare the blueprint. Okay, am I clear till now? Thank you. Okay, for example, again, if I take, I'm sorry, I keep taking pathology examples. I can't help it. I'm into that, and I hope, but obviously, yeah. So suppose this is another example, is that, for example, in pathology, formative assessment for second internal assessment. Okay, now I'll have to change it. Now we have only 20 MCQs, or as per the CBME, we have 20 MCQs and 80 theory, whatever. Now we can change that. Suppose it's the second term syllabus, CVS, RS, gastrointestinal, renal, hepatobiliary. Generally, I'm just taking, these are the predominant second term syllabus. Now we talk in terms of blocks, of course. Now we are talking in terms of blocks. Okay, so I can say that, see, we have from CVS, we have weightage. This is an arbitrary. I will show you how exactly we have divided is a different thing, that is later. But this is for example, suppose that is 20 marks. Respiratory is 20 marks, GI system 20 marks. We have to plot this first, this total number of our systems and what content areas, as well as a total weightage and number of questions that we have already decided. Now, after doing this, there are 2 questions, like, 2 long questions, 8 short essay questions, and 5 short answers of 3 marks total, and 25 marks of MCQs, which will make it to 100. Now, I have also included here the level of knowledge. Now, how many of you remember the level of knowledge that you had learned in revised basic course? Bloom's taxonomy you have learned? No, all MU members that I can know. Okay, that's very nice. So for your just to sum up, I will enumerate all the levels. The Bloom's taxonomy has 6 levels of knowledge, especially for a comprehension. For a knowledge domain. Okay, for a knowledge domain or a cognitive domain, 6 levels of higher order thinking or a higher order knowledge, what we call. The first level is a knowledge domain. This is for those who have not gone through revised basic course or don't remember maybe after a long time they're attending. So first is the recall, simple recall, basic level, like just remember the thing. What is tuberculosis caused by? Mycobacterium tuberculosis. Okay, that's a simple recall. Okay, so that is a recall. That's a very basic knowledge. The higher next level, second level of knowledge is the comprehension. They understand, okay, how tuberculosis spreads. What is the mode of infection? What is the pathogenesis of tuberculosis? Is that they know how. Now you must be, understanding the terms, knows and knows how. Recall is knows how is little more higher, they understand that. Then application, if they are able to apply that learned knowledge into the clinical setup or that patient or that scenario, then it is application. Still higher is an analysis, where they'll be able to analyze. Suppose if you give any lab parameters and the radiological findings and the clinical cases, the students will be able to gather all this, analyze everything and come to a conclusion. Okay, so that is analysis. It's again, because I'm a pathologist, I'm talking at the diagnostic level. It may be at the clinical level, it may be at the management level, it may be at the drugs level. At the drugs level, if the patient is not responding to the thing, there is a drug resistance, then what next to go in that given situation? So again, that is evaluation. Okay, the next level is an evaluation, and the next 6th level is a synthesis. So we have recall or a simple plain knowledge, the comprehension, the application, analysis, evaluation, and a synthesis. So evaluation and synthesis are considered as the higher order or highest order of thinking or a highest order of cognitive domain. So what we have to do is, most of the time, we usually end up asking questions at the knows-how level, at the lower level, maybe at the application level. We don't ask much of analysis. Fortunately, with CBME, you have started asking the clinical-based questions, scenario-based questions. That involves a lot of course, that involves a lot of their application as well as up to analysis. But with this, we can also, we have this in a blueprint, we also can think of having questions at the level of application, synthesis and evaluation also. Okay, we can go up to that level. So it helps us understand to go up to that level. And there are another blueprint is that There can be topic and how much of weightage is given to that. What is the domains of learning? How much weightage to be given is given at the domains of learning, and how much weightage is given to the tools of assessment, methods of assessment can be there. It can be mixed up with OSPI, OSCE, MCQs. It can be both practical as well as theory. You can have theory separate, practical separate. Better is to have both together and then separately, and then they should be in congruence, because we can ask one long question there. Suppose if the student, it happens, one long question is on CVS and the long case also they get a CVS. So most of the weightage for them, for that particular student, goes in that only. And whatever we have case. So better is that we have all these different plotted in the blueprint, so that there is no repetition of the cases, or there is no repetition, whether it is in the knowledge domain or in the psychomotor domain or any practical skills. Okay. Then this is another blueprint which shows, what tools can be used at a different formative as well as summative. See, for example, MCQs, SAQs will be used only for formative and summative, and OSLER can be used only for the summative, like that. Okay. Self-rating and other things for work-based assessment and all, only for the formative assessment, like that. We can also have this. I'm just showing you the different examples of how different blueprints can be. What are all the types of blueprints can be. It need not be only with the questions. Now, the most important, I'm sure that everybody is waiting, is this: blueprinting in the context of CBME. How blueprinting is going to help, and how we can going to utilize this, what is this role of blueprint in CBME. Okay. Before going into actual application, we'll just go through, we'll sum up a few of the things. We'll just refresh. What is CBME all about? What is assessment in CBME? Certain things that needs to remember, points to remember, we will just see. See, competency-based assessment is producing evidence to make a judgment about whether the person, that is the learner, is competent in relation to that particular standard. See the underlined words. If you see, we are producing an evidence or to make a judgment about whether that learner is competent enough for that particular standard, because we have to just set a standard. We cannot say whether attained or not attained. We are not saying just at what level of competency the student has learned. So we are looking at the level of the competency. That's very important. Then another few points to remember is that it requires some robust, multifaceted assessment, because multiple components are there now. There are so many, learning methods are there. There is integrated assessment, then there is ADCOM assessment, then there are other components like early clinical exposure, then electives. All these have come, and each one of them have assessment, right? All of integrated. So it requires multiple components are there, multiple tools, and multiple times, multiple exposure. So it is a multifaceted assessment. No single assessment method is sufficient here. No single or few is not sufficient. Then competencies can't be viewed dichotomously. In a sense, competencies can't say attained or not attained. No, we are looking at the level of the learners, how well they have attained, because we are setting a standards. At this standard, if they have to come, so we are setting at the level of the learner. So that also we have to remember. We cannot only say that yes, attained or no. So we will also have to see to it that they attain that particular level of competency, that standard that we have set. And it requires more time and resources for opportunities. I'm sure everybody will agree with this. Okay, resources, time, for faculty time, students time, everything. Then one more thing is training records and logbooks are not assessment methods. Many of them are saying that no, we have recorded. If it is there, it is there. It is there. It is there in the logbook. Then that means if the student has entered in the logbook, that means it is done. No, they're not assessment. They're only the evidence of assessment. That's only acting as an eligibility criteria. The logbooks act as only the eligibility, but they are not the assessment methods. Then assessment of skills is critical in CBME. What is one thing that has come up is, which is very critical in the CBME, assessment of skills, because most of the concentration is on those core skills, or what we say certifiable skills. The skills is very important. Then emphasis is on the direct observation rather than the proxy or surrogate assessments. Now, previously we used to give a long case, the short case there, and then that was done. But now, we used to consider that it is already done. Students have understood, but now it is not possible. That emphasis is on the direct observation. And now when we say emphasis on the direct observation, definitely direct observation is not possible only at one time in the examination, in the summative. So it has to be formative examination. And the formative is ongoing. Emphasis is only on the formative and the ongoing examination. So ultimately, assessment in CBME is a blend of both formative and summative assessments. So this picture beautifully depicts, this is a article, this is taken from an article, Dr. Mahajan and Tejinder Singh sir from 2007 article, that if you see that there is a perfect blend of, learning that's a formative assessment and a summative assessment. Both are, they go hand in hand, they have a perfect blend.
Press F5. Shift S. So can you complete that?
Okay, sorry. Okay, is it visible?
Not clear.
It's not clear?
Yes, madam. Yes, madam, it's visible.
Okay, it's visible. Okay, thank you, sir. So there is a perfect blend of learning oriented. I mean to say is a formative assessment as well as a summative assessment. They go hand in hand. They have to be perfect blend and they have to be coordinated well. That is important. The picture shows that they have to be coordinated well, along with self-assessment, workplace-based assessment reflections, which are ongoing, which are not at one periodical. They are not decided at one period, at the end of one block, at the end of this. Nothing like ongoing, round the clock. So that is what is an importance of ongoing. On the other hand, we see that the learner is attaining from a lower level to the higher level. So we don't talk of competencies in terms of yes or no. We talk of competencies in terms of at what level, lower level or higher level, or the standard that we have set. The same maybe what we can say is for a different level of learners, the standards may be different. For example, recording a blood pressure. The first year student may be at a lower level. They know how to do it. They know just they can demonstrate, and with the 20% of 30% accuracy also, like here there they can record a blood pressure is okay. But if the same student, same thing, BP recording at final year is at the higher level, we expect that 100% accuracy. There should not be any mistake. The way they follow everything. So that is the level of the learners, the competency level. That's what I mean. Okay, so this is how we'll have to go about it. Then in a blueprinting, when we start preparing a blueprint, when you think of a blueprint, the three things come to our mind: what to assess, when to assess, and how to assess, right? So what to assess, we already know the content. One is, if you go by the Miller's pyramid, this shows knows and knows how, that is the knowledge domain. Knows, patient knows, student knows and knows how. And this is a shows how and does. Most of our competencies are around this shows how. Does are very, very, very few, because does is that means it is not at the demonstration level or a skill lab. It is in the real life setup, in a real life patient. So does are very few. So most of our thing, though there are few does, but most of them are all in shows how, in the skills, and knows and knows how. This is what. And we know I'll not enumerate all the list now again, like, for knows and knows how, long essay, short answer, short essays, MCQs, Viva are there. For shows how skills, of course, we have OSCE, clinical case, long case, short case, demonstration with a checklist and attitudinal domain. There are so many things. Workplace-based assessment, all these are there. Okay. Now in the knowledge, then when it comes in this knowledge and then the skills and the attitudinal domains, that is the ATCOM component that is coming. No, ATCOM component is that it need not be only at the end of the module, those ATCOM modules only. ATCOM, of course, there are modules and their component are there, but round the clock through workplace based, somewhere we have to include assessing them for the communication skills, history taking skills in a day-to-day setup. And one more thing, generally when we say skills, we usually understand or we usually perceive it as a psychomotor skills, because that is what it has been stressed in our minds, during the revised basic course workshop. Hand, head, hand, and the heart. That's what we go. So skills means something that we perform. But if you have to think of skills, one is the practical skills that we do it, psychomotor. Another one is the intellectual skills. Intellectual skills are, can you give me some examples of intellectual skills? Decision-making skill, it may be. Right? Intellectual decision-making skills or critical thinking skills, or it may be reasoning skills. All these also we have to assess. Okay. So these are all the components that we need to assess. And at the same level, at the same time, we are also looking at how well they have learned. Okay. This is a famous Dreyfus model, what we call it is, on one hand, there is a skill and the time. As the time goes, we have to review the time, the learner goes on learning to the higher level of the competence, higher level of competence. So there are 5 levels of competence. One is the novice, that is the beginner. Then we have advanced beginner. Then we have a competent, and then proficient. And this is a expert. Positive outlier is a expert here. Generally we give, and again this varies. We give an example of beginner. Novice is an undergraduate student. Advanced beginner is an intern. A competent is a postgraduate or a staff, or like something like that. But it can also be at the level of first year student, advanced learner, or it may be at the same time, the first thing the student does, it may be advanced, and then next the student attains that competency and does it in a better way. Advanced beginner, and then a competent, and they become proficient. So we have to look at that level. Need not be proficient or an expert every time, but it is the standard that we set. At present, we are setting at the standard as at the competent. They should be at least the competent level. And some of them we have to look at the proficient, but at least the level what we are looking right now is they have to be competent in this. Okay. Now, when we prepare blueprints can be, we can prepare blueprint. One is for the formative assessment and the summative assessment. Because formative assessment is just not again one time and one episode, or one time we are doing it, periodical. So formative assessments is of 2 types. Again, one is continuous formative assessments, where we say round the clock with reflections, with their workplace based, round the clock assessment is going on without any time that we have put it over there. The other one is a periodical internal assessment that we have at the end of the block. End of the block, we have first IA, second internal assessment, like that. So we can have blueprints for those things also. Now, if you take again taking the same example, what I am putting here now is that time it was, one is the level of the learner, the comprehension or the synthesis or evaluation. Another one can be, these can be at the core, non-core competencies. Why I have put it here is most of the people think that we don't have to take anything from the non-core. It is not like that. Core is that core competencies are the ones which they have to attain to go to the next level of learning. I mean, the higher level of learning, or they have to be promoted to the next class. That is core competency. They have to attain that. But if non-core is like something like, okay, they should learn, it is there, but it's okay if they don't learn that to that level, then they can still be promoted, but they have to learn. Not that they should not be, because most of the time there was discussion. Wherever many people have asked me non-core, then why should you teach them also? Why should it be there? It's like something like desirable to know, what we say, desirable to know or nice to know category, something like that, let the student know. So we can include some questions also of that. So maybe around 20%, 10-20%, or up to 25% can be of a non-core competencies, whatever when we ask. That's why I put it as an example here. Then we can have, as I said, recall, synthesis, application at a different level of knowledge. Then we can also have one more as clubbing both. We can have core and non-core also. We can have the level of knowledge also, different level of knowledge also. Okay. So we can have it. Again, as I said, I'm showing different examples because it depends on us what kind of specification we want, we'll put. But the more the specification, the examination is going to be more specific. The assessment is going to be more valid. More the specifications that we are putting, more the details, then it will be, a validity goes on increasing with all this. Okay. So this makes us clear. We are not taking more than 80% of, more than 20% of non-core. We are restricting to non-core if we put it here like this. Then we can have a blueprint for practical examination, for practical exams and other things. Like this is one example. I've clubbed all different competencies, not particular to any particular professional year here. Just put it for understanding. This can be used for formative as well as summative. This can be used for formative as well as summative, because nowadays universities are asking us the blueprint. We are giving the blueprint to the university. It is we experts, and even whether it is Rajiv Gandhi University or any other universities or our redeemed universities, it is we, the faculty or the curriculum committee, who is preparing and giving the blueprint. So while preparing the blueprint, we can keep in mind so that no one person is biased while picking up the questions, while taking the questions. That can be avoided. So competence is related to the skills here. Talking of the practical, for example, if you are taking of a clinical decision making skills. Here, that's why I have not mentioned psychomotor skill or intellectual skill or anything particular to the skills. Maybe we'll consider it in a formative assessment. You can consider summative. So we can have whether we are going to take it in a formative, summative. or whether it comes in which domain it comes to, so that there is a balance of everything. And then what methods and tools we are going to use for clinical decision making is the clinical case. We can use a clinical or a case scenario, constructed case scenario. We can use OSPI, OSCE, or with the checklist, or in a workplace-based assessment. There are still many more. These are examples I have given. How we are going to assess the clinical decision making. I have an example of this in the next. I'll show you that. And the expected level is nose harm. Then recording a blood pressure. This can be asked in a formative assessment. For a summative, it is depends on us. Whatever we want to keep, subject experts, you can decide. And it comes under psychomotor domain. Again, this can be done with OSCE or observation with checklist, and then it is at the shows her level. Suppose if it's a history taking, again, we can keep it as a formative or a summative. This, as an example, I've shown it as formative here. It is an affective domain, and then it comes under the communication skills and affective domain also at COM. And OSCE or observation with checklist, again with the workplace-based assessment. Workplace-based assessment, if many of you must have not heard, those who have not undergone the revised basic course workshop, I understand that many people would have gone. Workplace is a concept that says, day to day when you are working, at that moment we are assessing in a real hospital setup, with the real patients and a real students, and there in a real scenario we are assessing in a day-to-day manner. For example, history taking. The student can decide and come and tell the teacher that today you assess me for my communication skills. I've taken history, and then there they decide, and then that can be done. So I'm just giving those examples here. So that can be done. And again, it is at the shows level. This can be for a shows level. The student can take a history. There's no harm to the patient here. Okay. Then taking consent. Again, see, if you see history taking and taking consent, they are at a different level. History taking is at at a lower level. Maybe the second year student who has just gone to the clinical can be at the shows how level for the history taking. But the final year student or an intern, if you take, or a final year student, maybe can be taught with a taking consent. Right? So there are communication skills are little complex. Issues are involved when they take consent. They have to explain the procedure. They have to make them understand, take a consent. Whereas history taking may be at a slightly lower level, taking consent may be at a higher level. Again, depending on the situation. Not necessarily that that is there. Depending on the complexity of the situation, it can be at the higher level. So it can be at the formative assessment. Again, the formative or communication skills. And again, here it can be with the OSCE or a role play, followed by the observation with the checklist, and this can be at a shows how level. So this is how I've just tried to put an example of how it can be done. Okay. Next is, okay, I have given an example here how we can build our OSCE stations where we can test these decision-making skills and critical thinking skills, and how we can build upon OSCE stations. I've just made an example here. Taking an example of a diabetes mellitus. Okay, the common example I'm taking, diabetes mellitus. I'm sorry, again, it is more related to the pathology, but I'm sure everybody can relate to it. It can be applied everywhere. Suppose if I'm giving now we have each one of us have prepared a cases on chart. We had a integrated teaching, and we had a case-based learning. We had a linker case with diabetes. We all have done that, right? Already. Now, if I put in one clinical case scenario with the diabetes mellitus, giving the features, polyuria, polydipsia, and all the typical features, and some urine examination findings, and this, okay, blood sugar findings and all that, the student will be able to directly understand. So that can be at the comprehension level. We should not waste our OSCE stations of 5 marks or 5 minutes for recall at all. Because if you recall can be assessed in MCQs or anything, we should not use the recall for such high marks and at the high stakes this thing. Okay, so we'll start with comprehension. Okay, they understand, they know it now very well. It is at the comprehension level. Now, next, how to take it to the level of application is that we can give diabetes mellitus with the complications. Give the findings of a complication, maybe some clinical scenario like nephropathy, complications of nephropathy, or renal complications like puffiness of the face, and give some urea, creatinine, something, and then along with all the diabetes features that the students will know, that will be able to assess. So they'll be able to learn knowledge, apply in this case. So that can be at the level of application. Then at the level of analysis, what we can do is construct a case or a diabetic with a clinical features of complication, asking for missing investigation to diagnose. Don't give some investigation. Purposely, we have to miss some investigation and ask them, what is your conclusion at this? What are your differential diagnosis? They should be able to understand the differential diagnosis also, make a DD and ask for investigations. There we can give the questions when you chart, when you are making asking, give the questions as like, why do you want to ask that? What are the other investigations? Justify the investigation you're asking. So there the reasoning skills also come. Reasoning and critical thinking skills will develop. So ask them, and then that can be up to the level of analysis. Then we can construct a case for a higher level still and give all of them findings and then ask them to come to a conclusion. What is the diagnosis? So this can be a clinical decision making skill. Okay, so evaluation and synthesis go hand in hand. In a clinical side, we can ask them diabetes with complications and a line of management. The patient is not responding to this oral hypoglycemics or whatever. Okay, oral hypoglycemic. So what to do? Give the situations and that. Let them take that. Clinical decision making. You can assess this along with that decision. To take the clinical decision, they will have to critically think, reason it out scientifically, and then come to that conclusion. So this is how we can create the cases, OSPI stations for a different level of to assess the different level of learning. Okay, so here the skills assessed are critical thinking, reasoning, and decision making. Now, why I put it here is that now these cases, once they are constructed, at what level we are going to put them in this? I'm sorry, in this table, where we are going to use those cases. We can have one more column here and see which of the particular case at what level we are going to use here. So like this, we must have created multiple cases in multiple areas. Tuberculosis or whatever the diseases, whatever we are teaching cases, and we have to think which cases at what level I'm going to use here. It has to go from higher level to the lower level. For block 1, or in the beginning, we can ask for a comprehension or a application. Block 2 and 3, we can ask something at a analysis or a synthesis level, right? So we can go on creating and keeping those level at this. So it is definitely going to help us make the make the assessment much more valid. Okay. So the next coming to we have the ongoing, like our assessment blueprinting for ongoing around the clock. Then we have certain certifiable skills. I'm sure we all have listed in our departments, in our subjects, we have listed certifiable and non-certifiable skills. For certifiable skills, again, we have to keep them in somewhere in the schedule. We have to, because we have to certify, we have to assess all the students. Out of that, one of them is also those EdCom skills. EdCom skills also come. So what we can do is include all of them, certain label the certified, write the certifiable skill competency, whatever the competency here, refer to the timetable and put it in the schedule there, in that whenever it is there, what method are we going to use? So for suppose we did this time, we included EdCom into our OSCE stations. We had communication skills and empathy and other things. So we assess them at the OSCE station, with OSCE stations. So include them, what methods are to, and what level, whether it is satisfactory or not satisfactory or more than expected, whatever levels, it is up to us to decide what level we are going to keep, set a standard, and again, think of that. And next time, if the student is not doing well, this time not attaining that level of proficiency, again, repeat test. If are we going to test them again to see to it that, with feedback, of course, we are giving CBME is all about, formative assessment with feedback. Give them a feedback and give them a chance. So next time when we are going to give them a chance, next time schedule, so that it will help us, because we have started now, we have seen that sometimes we forget to do that. Oh, that component has to be added. We forgot to add this. Oh, that was also there, because we are still learning with the CBME. All of us are learning. So we can have that, include that in the timetable. Like this, a blueprint, keep it in the department, then we'll know, okay, this is to be done. It's like a reminder, and everything will go smoothly accordingly. Okay. So that is about the that coming to an end. To summarize, competency-based assessment is a continuous, I'm sorry for that spacing here. Yeah, is a continuous process. It requires a multifaceted assessment. It requires a robust planning. And blueprint plays an important role in successful implementation of CBME, definitely. And it's a dynamic process. One more concept is that once we prepare a blueprint and keep it will follow. No, that does not happen. It's a dynamic process. It keeps on changing. The weightage keeps on changing. The modules, based on the feedback and how it works and all, it keeps on changing. Maybe not completely. To some extent, it will definitely change. Though the major structure remains the same, some things change. So it's a dynamic process that we have to remember and go ahead with that. So the take home message is, as George Miller says, assessment drives learning. Students are going to learn only what is being assessed and not what is being taught to them. So blueprint should be an integral part of assessment always, okay, to make the assessment more valid and meaningful. So more work in the short term, but it will pay off in the long term. And I'm just sharing here 2 of my articles that I had published on blueprinting. This was on how much is imprinted in practice. It's about the blueprinting, the steps of blueprinting and all. And the next time after that, I carried out a project for our students and in our department, and we implemented it, took the feedback and see how it worked and all, and we published. I can say that probably this is the first research or a project that is done on blueprinting. And so far it has received about 38 citations across the globe. Many of the Dundee University and other universities, Oxford, they've cited this article. So this is one I'm sharing here. And now I'm happy to share that in our department, we have made it as our practice. We have made a blueprint, and every year, this thing now and then we go on revising departments. Yes, we sit at we revise some things. Okay, everybody says, okay, you keep it, we'll keep it. Some things need to be changed, we change it. So that we are doing, and since almost 2015, it's become a part of our department. So that's how. Thank you so much. Thank you all for patient hearing and being interactive and responding to all. Thank you so much.
Thank you so much, ma'am, for very informative and very exhaustive and very, very much beneficial lecture. We are definitely will make use of it, and we definitely it has added to our knowledge. Now the session is open for QA session. There is, I have got a question in the chat box. Dr. Harsha Patil, his question is, role play is teaching learning method. Can this be considered as method of assessment for formal or summative assessment?
Yes, sir. Definitely it is a teaching learning method. But when we give a feedback and then we can assess them with a checklist, we can ask them to do the same role play and we will have a checklist. If it is associated with the checklist, definitely it can become an assessment method. It can be used as both assessment, teaching learning as well as assessment method. Otherwise, we'll not have anything else to assess our affective domain competencies. This is how we assess. We make them role play, we make them enact, make them demonstrate those skills, and then we assess it with a checklist. Definitely it can be an assessment method. So thank you for the question.
Ma'am, I need to ask you a question. I'm Dr. Neeta, ma'am.
1 second. 1 second, ma'am. There is a double. I think there is somebody asking question online.
Yes, ma'am. Can I ask you a question? I'm Dr. Neeta.
Go ahead. Please go ahead.
Thank you for the session, madam. Actually, I'm working on a blueprint with general surgery department.
Yes, madam.
But right now I have a query regarding we are doing formative assessments for second year. We have started the clinical assessments after every clinical posting for second years in all the subjects. So now when we are doing the blueprinting, they are like, should we go for the same? We are using OSCE as a method for formative assessment. So now we have to move, either we have to move away from the traditional way of long case and short cases, or should we continue with the formative assessment, the tool as OSCE? I'm not sure, ma'am, I don't know how to answer their query.
Probably I can suggest, madam. Ultimately, again, if you take this now as a CBME context, it is up to the department. You can do that. But suggestion is that completely don't do away with a long case or a short case. Keep them also. In addition to that, you can add some of these OSCE,
Okay.
the component of ASCII, especially for ATCOM and those communication and those kind of skills, as well as certain other skills are there in surgery, surgical skills. Definitely ASCII is very helpful. But at times, okay, again, if you don't construct those cases to assess the higher order of thinking, then it is very difficult to assess their higher order of thinking. So I suggest that to some till some time, probably you get used to, everybody gets used to the OSCE and all, how to construct OSCE. Better to keep both long, the cases also, in a short case or whatever you have. In addition to that, you can cut down on that a bit and you can add a bit of this. So it is better to have a blend of both.
Blend of both. Okay, can we go for one long case and then other thing? What I was thinking is, can I have one long case and we can replace those short cases with OSCEs, and they have the instruments as Viva, so we can
It can
include
be
that.
done, ma'am. It can be done. It can be done definitely. Again, it is I still feel you all have to sit in the department and you have to decide. Yes,
Decide.
it can be done.
Okay. Okay.
Yeah,
ma'am.
yeah. Ultimately, everybody should feel that, because see, first thing is I'm not from a surgical background, so
Huh.
clinical. So I will not be able to exactly tell you. So it is better that subject experts, but what you are saying is that can be done. If it is
Okay.
accepted and you all feel that is right, that's a perfect blend, that can be done.
Okay, ma'am. Thank you. Thank you so much.
Okay. Okay. Thank you, Dr. Neeta. Yes, madam. Sorry, here you were asking some question.
Madam, this is a bit of calculating when we say that we have divided it and then we give the weightage. And then we expect that this system should be asked up to 20% weightage should be on of the total question paper. And then we have a structured thing like this LAQ, SAQ, MCQ. We try to fit into that. But many a times instead of 21, it goes to 21.5.
It has happened with us also. I'm laughing because we have had that.
Yeah. So you know what? Is there any specification to this? Even how much it should increase or how much it should be the range? Is there a range to it?
Okay. I laughed because I smiled because we have actually faced this. When we were setting, array, this is going around this because 3 marks, 5 marks, and then it is going beyond that or it is falling. And we don't have 2 marks question. I ended up with 2 marks there. And 2 marks, that it has happened. That's why I smiled. What happens is, ma'am, again, we'll have to use our expertise. You have been there. We have been teaching for 10 years. So 1 or 2 marks here, there, something can be done. It's okay. That much, there is no hard and fast rule. There is no clear cut. We don't draw a line. Okay, beyond this, there's nobody. So that weightage also was decided by us only. That weightage, whatever we take 20, 15, 18, whatever, 60, whatever we have, that was also decided by us only. So when the practical question comes like this is really difficult. I completely understand. Because when I did my, my project, I have sat together for days together to adjust those rates, इधर से ज्यादा किया तो उधर कम होता था, इधर से ज्यादा किया तो इधर होता था. It is not that simple. And so होता है, that's okay. So little here, there, we'll have to adjust and use our expertise in the discretion. Exactly. Thank you for that question, madam.
So many teaching learning days are there.
Yes, sir.
What every faculty knows is the self-directed learning. How to assess?
Again, actually self-directed learning, there are many methods. Again, for that also assessment is again the same sense, sir. You give them an assignment. Based on that, we are doing it. We give them seminars, project works, make them posters. There are different methods. And based on that, we are judging. That's how we are doing. We are also doing. There is no different separate method, assessment method as such. These are all the assessment methods. Depending on what we give, we are doing it. Like, for example, ATCOM, what we did was, we asked them, we divided them into 10 students. So we had 180 groups actually. 3 of us divided into 60, and we gave them the scenario and we told them, you can do it in any way you want. You create a scenario and this. They did it wonderfully and we assessed based on our checklist. We have to have a checklist. So similarly, if they are doing a seminar, sir, Or if they're doing posters, once we give them to make a posters, we give them a topic and make posters. They make beautiful posters and all that. So based on that, when we have a checklist again, and we have to make that. There's no hard and fast rule or a specific criteria that we have to judge like this.
I have got a question.
Yes, ma'am.
As you say, even non-core competencies should be assessed. My question is, when so much of core competencies are there, which are actually needed to be assessed, when these non-core competencies are nice to know or desirable to know, so why to
Waste them.
Waste them? Why we
Okay,
waste
so
in
the-
assessing them instead of assessing core competencies?
Okay, the question I think for online people, if I can say that question is that when there are core and non-core, when there is so much of area in the core itself, why you ask a core question, non-core question and waste the 10 marks, 5 marks or whatever percent. Okay. Now, madam, what happens is if it is core or must know what we say or must know or a core, then everybody, most of the majority of the students who are there in that average, this thing, everybody will answer that. They will do that. We also are looking at our education system is looking at differentiating a poor performer and a good performer from an excellent performer, right? So to differentiate, that's why it's only about 20%. We should not ask more than 20%. Not necessarily that every time you have to ask, you can ask some, at least up to 20% you can ask. So that at least we should be able to differentiate those performers, otherwise almost most of them will come up to that. It is those 20%, I'm sure you will all agree if you have seen, it is that 20% that differentiates the, the excellent performers and advanced performers or advanced learners or this one performance. So I think that should be there as per the system of our education, that should be there. Thank you. Thank you for that question, madam.
Any questions?
Yes, Dr. Wasim Ansari, he is saying assessment should be comprehensive, inclusive, comprising core and non-core. Yes, sir, very true. Thank you for that comment. Yes, madam.
I have one doubt.
Yes, madam.
You have shown that slide, proficiency to, if he has not got the proficiency, then how many times to repeat? Repeat the assessment.
That is your,
Because very less time is there.
you decide, madam. Again, that's what I said. You have to decide and you should give a feedback in such a way that the student picks it up. If your feedback is very specific, because we also say that whenever something is performed, it cannot be 100% wrong. The student would have done something right, something small, some other thing would have gone wrong. So we focus on that. That's why it is on observation. That's why I always see that all this is on observation. We have to observe specifically and give the specific. Next time the student will definitely improve. So it depends on us how many times we want to do that. We have to make them competent. We have to make them competent. We have no other alternative. We have to make them competent if they have to go to the next level, especially for the core. A high level. That is the standard level. High level in the sense, whatever level we have set. Naturally, we will have to set that competence at least that level. So till they reach that level, we have to do that. Benchmark, of course, that has to be there. So give them an opportunity, give them time, repeat, tell them, these are the things, and they will definitely do. I don't think they will take more than 2-3 attempts because students are smarter than what we think. So they will pick up. And once that's what, again, assessment drives learning. Once they know that I have to learn this assessment a competency, I have no other alternative. I have to go to the higher level. I have to learn. They will learn. They will learn. Yes. Yes. Thank you, madam. Okay.
Questions? There are no more questions in the chat box.
Yes, ma'am. Thank you. So we'll, I'll log out.
One more question.
Yes, ma'am.
Can you really give us some hints for preclinical departments to increase the domain level in questioning? Because that is a clinch, and for preclinical department, usually to recall knowledge cases more. We try to put it cases, we try to put it some application domain, but still we feel a bit short of it.
Yeah, yes, definitely. I completely agree that the preclinical is something where At least in paraclinical, we have cases, we have so many clinical and we have such, that is anything that is pathology that is happening. Most, I mean, anything abnormal, pathological, I'm just talking. So preclinical, it is difficult. I completely agree. But again, what I say is, ma'am, you have to sit and think in what way we have to increase. In what way we can do that. It takes definitely a lot of time. Like I gave an example. That's why I gave an example that we can go on building up like this. So similarly, maybe you can start with and then asking the mechanism of something like that, and then maybe we can give a clinical application to some extent, some clinical application, make it interesting, because students feel it is very dry. Usually, with pre and paraclinical, they feel it is dry, and the clinical they like. That's natural. So we have to make it interesting for them and give them kind of clinical application. So shall we log out? We'll have to think. Okay.
Thank you, ma'am.
I hope our ma'am has cleared everyone's doubts or questions which we had.
Thank you so much, ma'am. Now I request Dr. Madhya Mane, Professor and Head, to felicitate Madam